So today I will be presenting on vasoplegia in the cardiothoracic surgery population. And like Ali said, my name's Anna. I'm the PGY2 in critical care this year. And I would just like to thank my advisor, Jen Lai, who helped me put together these slides and was my content expert for my presentation today. So after this presentation, I hope that all of you will be able to describe the clinical appearance of vasoplegia in the setting of cardiac surgery and explain the causes and pathophysiology of vasoplegia. Further, I hope that you'll be able to identify agents that we use for treatment of vasoplegia, including their mechanisms of actions, potential side effects, and other considerations we have. And lastly, we will analyze the evidence for use of these different agents for treatment of vasoplegia, and we'll specifically focus on what we use when vasoplegia is refractory to pressors and other first-line agents. So before we start, I will introduce our patient, JJ, who will be our patient that will follow throughout the presentation. He's a 56-year-old male who arrived to the Cardiothoracic intensive care unit following a CABG due to an end-STEMI. He has a past medical history significant for depression, hypothyroidism, type 2 diabetes, hyperlipidemia, and hypertension. I have his inpatient medication list on the right side here. So I would just like to point out we have some prior to admission medications that we've continued for his chronic disease states, but then also note that he's intubated and sedated with propofol and he has fentanyl. He also has 3 pressors going, so epinephrine and norepinephrine, and then vasopressin as well. Hemodynamically, JJ has a normal cardiac index of 2.8 and a low systemic vascular resistance at 780. His MAP, or mean arterial pressure, is low at 59, and his blood pressure is also low at 88/44. His heart rate is 76 beats per minute. So the team approaches you and says this patient has a vasoplegia associated with his recent cardiac surgery. So maybe you're a Cosmic A resident staffing the PM shift or a cards weekend. What can you expect next, or what should you be thinking of next? This leads us to our first objective of describing the clinical appearance of vasoplegia. So as we know, there's different types of shock, including distributive shock, obstructive shock, hypovolemic shock, and cardiogenic shock. Vasoplegia in cardiac surgery is a specific type of distributive shock, and it accounts for about less than 5% of all shock states. But in those who have cardiac surgery, the incidence ranges from 5% to up to 50% of patients experiencing vasoplegia. And in this population, the mortality rate can be as high as 25%. So risk factors for post-op vasoplegia include a pre-op antihypertensive use, having a low ejection fraction, having diabetes or a recent myocardial infarction, or surgical characteristics such as having a long duration of cardiac bypass or having a warm core temperature while on bypass. So clinically, vasoplegia is referred to as a high output shock state. So this means that the systemic vascular resistance is low, but the cardiac output is normal or is elevated. So the output of the heart isn't necessarily impaired, but it's rather the vasculature that's dysregulated. And this dysregulation of the vasculature leads to vasodilation that's refractory to our normal treatments, hypotension, and hypoperfusion, which, as we know, can have consequences when that hypoperfusion is prolonged. So vasoplegic syndrome, or vasoplegia, is not very well defined. There's no widespread standard definition, but it is really similar to other shock states like sepsis, but it's different in its cause. So instead of infection as the cause, it's the cardiopulmonary bypass. So in general, it's thought to be hypotension that's refractory to pressors. And numerically, this would look like a normal cardiac index of greater than 2.2 and an SVR that's low or less than 800. And so for vasoplegia in the setting of cardiac surgery, this would be occurring within 24 hours of cardiac bypass. So with this background, let's test what we've learned so far with our first knowledge check. And so please feel free to put your answer in the chat. The first question is, true or false? JJ's hemodynamics do not align with the clinical definition for vasoplegia. And as a reminder, I've put his hemodynamics here on the right side of the screen. And so true or false, they do not align with the clinical definition. All right. I'm seeing some falses. Okay, good. So you're correct. The answer is indeed false. So as a reminder, vasoplegia is vasodilatory shock with a normal cardiac output. So for cardiac index, that's greater than 2.2, and a low SVR, so less than 800, which JJ's hemodynamics align with this definition. So now that we know what vasoplegia is, let's move on to more of what causes it and the mechanisms behind it from a pathophys standpoint. So normally our vasculature responds to hypotension by activating G protein coupled receptors. So this is getting a little bit more into the exact mechanisms, but I think it helps us understand some of the agents we use to target vasoplegia. So with activation of G protein coupled receptors, this would include a lot of receptors we're familiar with. So alpha receptors, which are activated by catecholamines, or vasopressin 1 receptors that are activated by vasopressin, and angiotensin receptors, which are activated by angiotensin II. So these receptors cause an increase in this intracellular calcium of the vascular smooth muscle cells, which causes the vascular smooth muscle cells to contract and causes vasoconstriction and increases in blood pressure. However, following cardiopulmonary bypass, this normal physiology is disrupted, and this leads to vasoplegia. So again, I'll present a few different mechanisms behind it, and keep these in mind as we go through the agents later, because again, these are our targets for therapy. So when blood comes into contact with the cardiopulmonary bypass circuit, some inflammatory cytokines are released. So things like interleukin-1 or interleukin-6 and TNF-alpha. These inflammatory cytokines induce nitric oxide synthase, which increases the production and release of nitric oxide. And nitric oxide has two main effects that we'll discuss. So first, it inhibits calcium influx into the smooth muscle cells. So normally, calcium influx would cause vasoconstriction, but by inhibiting this influx, that leads to vasodilation. Nitric oxide also activates soluble guanylate cyclase, which increases the production of cyclic GMP, which causes vasodilation. The second mechanism behind vasoplegia is through the adrenergic system. And so the same inflammatory cytokines that induce nitric oxide synthase are also responsible for causing hormone depletion and disruption. And they also desensitize the adrenergic receptors. So the catecholamines like epinephrine or norepinephrine lose their effect at these adrenergic receptors, which leads to this resistant hypotension. And lastly, vasoplegia can be mediated by hydrogen sulfide. And hydrogen sulfide is produced from L-cysteine, and this agent acts on the potassium pumps on the cells, causing hyperpolarization and decreased contraction. So that leads to vasodilation as well. So again, these will be the targets for the agents we'll discuss. But before we discuss the agents, let's do another knowledge check since we've learned more about the physiology or pathophysiology as well. So this one is a multiple choice. Which of the following is a mechanism underlying vasoplegia? A, decreased production of hydrogen sulfide. B, increased sensitivity of adrenergic receptors. C, increased production of nitric oxide. Or D, decreased production of inflammatory cytokines. And again, feel free to throw your answer in the chat. All right. I see a C. I see multiple C's. Okay, good. So you guys are correct. The answer is increased production of nitric oxide. The other things are all the opposite. So increased production of hydrogen sulfide, decreased sensitivity of those receptors, and increased production of inflammatory cytokines. All right, so next we'll move on to the meat of the presentation, which is more of the discussion of our management of vasoplegia. And we'll talk about the medications that we use to do so. And so the section of this presentation will be kind of combining objectives 3 and 4. So we'll discuss each agent and their mechanisms, their dosing, side effects, and other considerations, since they aren't medications that we use in a ton of patient populations. And then as we discuss each agent, we'll also evaluate some of the evidence for each agent. So when a patient is presenting with hypotension post-operatively, there's a lot of other therapies that we should ensure have been implemented or at least considered before we jump into the agents that I'll discuss next. So first, fluid boluses can help maintain pressures in some patients. A lot of times, though, during cardiothoracic surgery, patients often receive a lot of fluid intra-op, but a trial of fluid boluses can be a good first line to help stabilize pressures initially. And of course, pressors will be used in these cases too. Oftentimes, patients come back to the floor on a lot of pressors. And so often these catecholamine pressors like norepinephrine or epinephrine are used, but adding vasopressin or the non-adrenergic acting pressor can help with that adrenergic desensitization that can occur. And then using things like steroids and ascorbic acid or vitamin C are also proposed, and some of them are used more in the intra-op setting. So there's some evidence to suggest benefit for those, but we won't go into that evidence today for time's sake. All right, so the agents we'll discuss today include methylene blue, hydroxocobalamin, and angiotensin II. And before we dive into each agent, I'd just like to take a moment to show some cost comparison between agents. And these prices here are based on the average wholesale price that LexiComp includes. So it's not specific to UW pricing exactly, but it should be a good comparison between the 3 agents. So as you can see, angiotensin II is the most expensive for a bag. And then the hydroxocobalamin, 5 grams is a typical dose, so almost $1,000. And then methylene blue is 50 milligram vials, have a price of around $300, but most doses might be around like 100 milligrams, so that might be a little bit higher of a price. And so when we go through each agent and you're kind of thinking through the process of picking an agent to use, keep these cost considerations in mind. So let's start with methylene blue. Methylene blue acts on the nitric oxide pathway that we discussed earlier, and it works by inhibiting guanylate cyclase. And so by inhibiting this guanylate cyclase, it decreases the production of cyclic GMP, which decreases that production and inhibits vasodilation. So methylene blue for the indication of vasoplegia is actually off-label use. Its approved indication is methemoglobinemia, tongue twister, but it does have some evidence for use for vasoplegia. The dosing can vary, but typical dosing is around 1 to 2 milligrams per kilogram over 20 to 60 minutes. So some important safety considerations to have would be some contraindications or warnings. So for patients with a G6PD deficiency, methylene blue is contraindicated because of the risk for hemolytic anemia. And it also has a black box warning for use with serotonergic medications due to risk of serotonin syndrome. Adverse effects can vary for methylene blue, but notably it has a high incidence of limb pain. And it is this blue color to align with its name, so it can cause some skin discoloration or some urine discoloration as well. And lastly, one thing to note is that it can interfere with the pulse oximetry readings, showing an abnormally low level when actually oxygen saturation is normal. So the first trial that I'll discuss is regarding the use of methylene blue in the cardiac surgery population. And it was a randomized control trial that randomized patients to get 1.5 milligrams per kilogram of methylene blue or placebo. And this study included 56 patients who had elective cardiac surgery. They had to meet vasoplegia criteria to be included. And so this vasoplegia criteria included hypotension with a mean arterial pressure of less than 50, a low filling pressure, which was shown by CVP less than 5, or a wedge pressure less than 10. They had to have a high or normal cardiac index and low peripheral resistance, so meeting that kind of definition we shared earlier. Patients were excluded if they had an off-pump CABG or bypass, if they had bacterial endocarditis, if they had an aortic dissection, or if their procedure was urgent or emergent. Again, these were only elective procedures. So those who received methylene blue had a lower mortality rate compared to those who did not, with a significant p-value of 0.01. Additionally, those who received methylene blue had a shorter duration of vasoplegia of about 2 hours. Those who did not receive methylene blue had a longer duration, with almost 30% of patients who did not get methylene blue having a duration longer than 48 hours. So, of course, this study has its limitations that we need to keep in mind. Oops, sorry. So despite the benefit that this study suggests, we need to keep in mind that it has a small sample size. And also with the exclusion criteria, it doesn't apply to all of our cardiac surgery population. It kind of leaves the questions of asking, in certain subgroups of patients or those with urgent or emergent procedures, would the benefit still be seen? So I think this does suggest some mortality benefit and some benefit to getting methylene blue, but more to come. So some studies actually suggest that there's a benefit to giving methylene blue intra-op instead of in the ICU post-op. And so this study was the next study here is a retrospective cohort study that looked at over 3,000 patients, but they looked a little bit closer at 118 patients in that group who underwent bypass surgery and got methylene blue within 72 hours of bypass. So most patients got a dose of 2 milligrams per kilogram as a bolus, followed by a 12-hour infusion of 0.5 milligrams per kilogram per hour. And so the primary outcome was adverse events, which included a composite of operative mortality, and then, sorry, it's cut off a little bit here with the font change when I downloaded it, but the second part of the composite outcome was adverse effects like stroke, renal failure, reoperation, external wound infection, and they also included prolonged ventilation in that outcome. So it's a pretty big primary outcome. So they looked at kind of two different groups in this study. So they looked at methylene blue, so the 118 patients who got methylene blue versus the over 3,000 patients who didn't get methylene blue, and compared them that way. And then they also looked to compare groups of those who got methylene blue. Let's compare the early patients, so who got methylene blue in the OR versus the late group who got methylene blue post-op in the ICU. So when comparing those who got methylene blue to those who did not, I think it's important to remember that not all patients in the no methylene blue group had vasoplegia. So that makes the analysis not a true control group because those patients weren't as sick. So in simple terms, the methylene blue group was a little bit sicker. They were younger, but they had more heart failure with a lower ejection fraction. They had more ventricular assist devices, more chronic lung disease, and more prior cardiac surgeries. And they also had more preoperative amiodarone use. So some suggestion of cardiac instability there. So as a result, then, the methylene blue group had a significantly higher rate of major adverse outcomes and a higher rate of mortality specifically. And so again, interpreting these results cautiously because the methylene blue group was likely sicker, which prompted the use of methylene blue. And again, the second comparison that they looked at was early administration versus late administration. And overall, they found that the early, let's jump to the bottom bullet point first, the early administration had reduced rates of renal failure and actually had reduced operative mortality. So this subgroup that's looking at early versus late, suggests that there may be some benefit to giving it in the OR rather than back on the floor. Overall, though, this study found that methylene blue administration was associated with decreased pressor requirement and increased MAP and SVRs. So on the right, you can see the results. So the mean arterial pressure went up and was pretty well sustained. And then the epinephrine and norepinephrine requirements went down over time. So overall, the benefit of methylene blue was kind of difficult to establish in this study because it wasn't associated with increased mortality, but if given early, that may be associated with reduced risk of major adverse events. And so the limitations of this study include that it's a retrospective study. So I think that's important to remember. And again, it's a pretty small population. And many other confounders exist because of this retrospective design. And so a lot of these confounders that could be affecting the outcomes would be surgical characteristics or patient characteristics. The last study that we'll discuss is a systemic review and meta-analysis of methylene blue. And so this analyzed 6 studies of the use of methylene blue in the cardiothoracic surgery population. And they compared those who got methylene blue versus those who did not get methylene blue. And this included about 317 patients overall. When they compared MAP, SVR, heart rate, and length of stay as outcomes, this analysis found no difference between treatment groups for these outcomes. However, when the same population looked at renal failure, multi-organ failure, and mortality as outcomes, this analysis actually found benefit in the methylene blue group, with lower risks of these outcomes in the methylene blue group. And so I'd argue that this slide here has the more clinically significant data points than just the hemodynamic outcomes alone shown on the prior slide. So this meta-analysis suggests that methylene blue may have some benefit in this cardiothoracic surgery population. So overall, although the data we have for methylene blue is limited and there's no huge, large randomized control trials that we typically see for drug approval, the data we do have suggests that there may be a mortality benefit with methylene blue for the cardiothoracic surgery population with vasoplegia. And then it also suggests that early administration may be more beneficial, but I think that still needs some more investigation and larger studies to determine that. So despite this evidence, it's still considered off-label for use. So we should make sure, as pharmacists, we're ensuring that it's used safely if it is used. So next, we'll discuss the use of hydroxocobalamin. Hydroxocobalamin targets a couple of the mechanisms of vasoplegia that we discussed at the beginning of the presentation. So it targets the nitric oxide pathway, but also the hydrogen sulfide pathway. So it binds and inhibits nitric oxide, but it also binds and inhibits nitric oxide synthase. So it inhibits the action of nitric oxide and the production. And it also binds to hydrogen sulfide and increases its elimination. So that inhibits vasodilation through that pathway as well. Hydroxocobalamin is also considered off-label for use of vasoplegia. And it was actually started to be used for vasoplegia because of a side effect noticed for its labeled indication of cyanide poisoning. So for patients who got hydroxocobalamin for cyanide poisoning, they found that hypertension was a side effect. And that's how we use it today for vasoplegic syndrome. So the dosing recommendations for vasoplegia mimic those for cyanide poisoning. But also there's some case reports and case series that maybe suggest a prolonged infusion has benefit as well. So the typical dosing, and probably most common, is the 5-gram bolus over 10 to 15 minutes. And you can repeat the dose once for 10 grams total, or you can do a bolus followed by an infusion. Hydroxocobalamin is most commonly supplied in the injection kits, which are known as the cyano kits. And again, it's only FDA approved for the use of cyanide toxicity, but this is what we would use for vasoplegia as well. Hydroxocobalamin has a couple notable side effects. So first, discolored urine is probably the most common, 100% of patients, so it's something we can expect and it can last for a while. It's also associated with erythema, rash, or infusion site reactions as well. Hydroxocobalamin can also interfere with some labs, and so that's important to be aware of as well. So first, on certain dialysis machines, hydroxocobalamin can actually cause a blood leak alarm because of its red color. So this is because the machines that use photo technology to detect changes in the dialysate color to try to detect blood are kind of tricked by this red color of the hydroxocobalamin if it leaks into the dialysate. CRRT machines are not as effective, so if a patient is really hemodynamically unstable and on CRRT, this isn't as much of an issue. But it also can cause some false changes in LDH, hemoglobin, alk phos, glucose or serum creatinine, and even INR and prothrombin. So as pharmacists, we can help the team recognize these lab abnormalities as potentially due to recent hydroxocobalamin use. So at UW specifically, we do have some formulary restrictions and considerations to be aware of when it comes to hydroxocobalamin, whereas with methylene blue, we don't have as many considerations from a formulary perspective. So for hydroxocobalamin, patients need to have vasoplegia refractory to adequate doses of norepinephrine and or vasopressin to achieve their MAP goal when given for at least 10 minutes. And this adequate dose is not clearly defined, but so I think this is where some clinical judgment comes in. And an authorizing attending has to co-sign on the order or be a part of the decision. And then we must have 2 kits always available in central pharmacy to be available for cyanide poisoning. So that emergency situation, not that vasoplegia isn't an emergency, you could say, but there are other options that we could use as well. So we always need to ensure that we keep 2 cyano kits in stock in central pharmacy. So the first study I'll discuss for hydroxocobalamin is a small retrospective case series. And this studied 33 patients who had cardiac surgery and received hydroxocobalamin for vasoplegia. They got it as a 5-gram bolus over 15 minutes. The patients who received hydroxocobalamin were patients who had vasoplegia refractory to at least 0.1 mics per kg per minute of norepinephrine, and 0.04 units per minute of vasopressin, but then also, it's cut off here, but they also had to be on 0.1 mics per kilogram of epi. So despite these 3 pressors, if they were not able to maintain their MAP above 65, then they would qualify for hydroxocobalamin. And so then investigators reviewed vasopressor dose as the primary outcome, and they reviewed this as at 5 minutes before administration, at administration, and then 30 and 60 minutes post-administration. So the results of this case series are pretty interesting, and they were reported based on groups of patients based on their response. So some groups of patients had a robust response with up to a 50% reduction in vasopressor dose. However, some patients did not have as much of a response and showed almost minimal response to hydroxocobalamin. And interestingly, the patients who showed the minimal response actually were the sickest patients. So these were the patients who had a longer time on bypass or who had a longer length of stay or longer time on the ventilator. And so while some patients showed a really promising response with that vasopressor dose reduction of almost 50%, the case series is somewhat difficult to interpret and to apply to practice because of the small population size and the variable response. And additionally, not all patients that were studied received hydroxocobalamin only. About half of patients also received methylene blue as well. So that's important to keep in mind that the effect seen in this study can't be only attributed to hydroxocobalamin. And so given this, there's some limitations to the external applicability of the results, but there is some suggestion of benefit from this study. So the next study actually focuses also on patients post-cardiac surgery. And this was another IV bolus of 5 grams over 15 minutes, but the patient population size was much smaller. So it was 7 patients, and they got the 5-gram bolus dose within the first 24 hours post-operatively. And this study didn't have to meet certain pressor requirements necessarily to qualify for hydroxocobalamin, but it was more so at the decision of the surgeon or the intensivist. The primary outcome that they analyzed were change in MAP, and then they also looked at change in vasopressor rates. And they looked at these changes at pre-administration, early post-administration, so within 1 hour of getting the medication. They looked at it 1 hour and 2 hours post-administration as well. These investigators found that the mean change in MAP was almost a 10-point increase, and the mean vasopressor requirement decreased by about 20%. Most of this benefit was actually seen in the earliest measurement post-administration, so within that 1 hour of getting the dose. But despite these promising outcomes, I think it's important to remember some limitations, as always. There was no statistical analysis because of the super small population size. So again, it's hard to externally apply this retrospective data. The last hydroxocobalamin study we'll look at had the aim of assessing the effect of a prolonged infusion of 5 grams of hydroxocobalamin instead of the 15-minute standard bolus. And so the infusion length was per the decision of the prescribing physician, and it had a maximum infusion duration of 6 hours, and this was based on the beyond use state of the medication. And the primary outcome, again, was change in vasopressor dose. So this study also found a benefit in hydroxocobalamin with a significant reduction in vasopressor dose. So you can see here, the infusion was for about 6 hours, and that's about as long as the box here in green, so the median infusion duration. And that's when the most dramatic decrease in vasopressor dose occurred. But again, this study has similar limitations. So it's a small sample size. There was no comparator group. And it is interesting, though, that it does propose some benefit of a prolonged infusion. But again, more evidence is needed to support this dosing practice instead of the IV bolus. So overall, very similarly to methylene blue, hydroxocobalamin is off-label use, and it has limited data. There's no randomized control trials for this specific population, and it's largely based on case reports or case series that are limited by bias, of course, and small sample size. And mortality was not a well-studied outcome. So unlike methylene blue, we don't know its impact on mortality as well. So now that we have methylene blue and hydroxocobalamin discussed, I would just like to take a moment to compare these two agents with some data that's available. So I'll present 3 different studies that compare the two agents. The first is a retrospective cohort study at an academic medical center, and they analyzed 16 patients who got methylene blue and 19 patients who got hydroxocobalamin following their cardiac surgery. The primary outcome was change in norepinephrine equivalents in the hour after administration. And it's important to note here that the methylene blue group had a higher Apache 2 score, so this might have played an impact in the outcomes. Neither hydroxocobalamin or methylene blue had a significant change in their norepinephrine requirements at 1 hour post-administration. And between the two groups, there was no difference between the norepinephrine changes. So this study doesn't really support any difference. The second study was also a retrospective cohort study at a tertiary medical center, and they analyzed 14 patients who got methylene blue alone, and then 6 patients who received a combination of methylene blue and hydroxocobalamin. The primary outcome in this study was the ability to maintain a MAP above 60 beyond 1 hour after medication administration. And these investigators actually found no difference as well between the groups in their ability to maintain their goal MAP. However, they did find a significant reduction in the proportion of that initial vasopressor dose that was still required in the combination group at 1 hour and 6 hours. So maybe there's some benefit to using both agents together. The last study we'll discuss that compares methylene blue to hydroxocobalamin is another retrospective propensity-matched cohort study at an academic medical center. And they analyzed 66 patients who got methylene blue and 22 patients who got hydroxocobalamin. And again, their primary outcome was change in vasopressor dose at 30, 60, and 120 minutes post-dose. And they found, similarly to the others, no difference in vasopressor dose between the groups. However, they found a difference in ICU and hospital length of stay, seeing that it was longer in the hydroxocobalamin group, but this was not associated with a difference in mortality. So overall, the data is not extremely strong that compares the two agents. It's largely retrospective. That's a common theme with a small population. And so there may be some potential benefit to methylene blue over hydroxocobalamin, given its mortality data that we discussed earlier. And the results of the last study here show maybe there's some benefit with length of stay. However, I think what we should take away too is that it's important to tailor therapy to each patient, along with remembering formulary restrictions as well. And that will be the important part in making that decision. So now let's apply what we've learned so far about methylene blue and hydroxocobalamin. It's been a while since our last knowledge check. Okay, so let's remember our patient JJ. I know we talked about him way at the beginning of the presentation, but now the physician is trying to decide on using either methylene blue or hydroxocobalamin. So for him, what do you recommend? A, methylene blue, or B, hydroxocobalamin? And I won't let you struggle for too long because I know his information was presented a while back. So I included his medication list and his past medical history for your reference. So again, A was methylene blue, if that's what you would choose, or B is hydroxocobalamin. Or you can just take a 50-50 guess if you don't know.
I think some of that.
All right, I'm seeing all B's. Okay, good. So you guys are right who answered B. The answer is B, hydroxocobalamin. And the answer here, for those who answered B, you probably caught on that the answer lied in his medication list. So again, since JJ is on two medications that could increase the risk of serotonin syndrome with methylene blue, hydroxocobalamin would be the better choice here. So now let's move on to our final agent, angiotensin II. So we'll take a moment to review the well-known renin-angiotensin-aldosterone system. So as we know, angiotensin II is converted to angiotensin I by renin, and then angiotensin I is converted to angiotensin II by ACE, and then angiotensin II binds to the angiotensin II receptor, causing vasoconstriction. So in patients with lung injury, ACE is not produced in high enough amounts. And so it's proposed that cardiopulmonary bypass mimics that, so a lower production of ACE. So more is diverted from this angiotensin I to angiotensin II pathway to production of other forms of angiotensin that are actually associated with vasodilation. And I'll discuss this more. So to show this, I'll talk briefly about the effect of ACE inhibitors in the setting of cardiac surgery. So in addition to cardiopulmonary bypass causing vasodilation, ACE inhibitors can also play a role if they're used close to that operative time. So by inhibiting ACE, we inhibit the production of angiotensin II and that vasoconstriction, which we all know. But similar to how I described on the previous slide, when we inhibit ACE, this causes a shift from angiotensin I into angiotensin I-9, which causes a shift to production of angiotensin I-7, which is associated with vasodilation. And so the use of ACE inhibitors prior to surgery may be associated with more shunting to the angiotensin I-7 production, leading to more vasodilation and intraoperative hypotension. So that's why at UW, especially if you staff cardiology, you'll see like a note order to hold prior to surgery and to restart when able. And so this hold time might vary actually depending on the half-life of the ACE inhibitor that we use, but just a consideration to keep in mind on any sort of floor or unit that you staff on. So the initial dose for angiotensin II is 10 to 20 nanograms per kilogram per minute, with titration every 5 minutes to reach our goal map. And once we reach that goal map, we can down titrate every 5 to 15 minutes as the patient tolerates. It's important to note here the maximum doses of angiotensin II. So initially, the max dose is 80 nanograms per kilogram per minute during the first 3 hours. But then after that first 3 hours, the maintenance dose and the maximum dose reduces to 40 nanograms per kilogram per minute. So this is largely due to how it was studied, and I'll go through that shortly. So at UW, there are some restrictions for use of angiotensin II based on its indication. So the septic shock restrictions are different than the cardiac surgery vasoplegia restrictions. So for post-cardiac surgery, use must be approved by the attending physician, and they, like hydroxocobalamin, have to show failure of adequate doses of norepinephrine or vasopressin to achieve their goal map. And then the patient also must have shown an inadequate response or have a contraindication to methylene blue or hydroxocobalamin. So we prompt the use of methylene blue or hydroxocobalamin first, and angiotensin can be that more second-line agent. So the main trial that led to the approval of angiotensin II was the ATHOS-3 trial. It was a phase 3 double-blind placebo-controlled trial where patients were stratified by their MAP and their Apache 2 score to angiotensin II versus placebo. And again, sorry that this is cut off, but there were 163 patients in the angiotensin II group, and then I can't remember how many were in the other group, but it was a similar number. And the primary outcome was MAP response at 3 hours. And they defined MAP response as an increase in mean arterial pressure of at least 10 or an increase to at least 75. And this should be without an increase in other background vasopressors. So just to tease out the benefit of angiotensin II. Secondary outcomes that they looked at include all-cause mortality, but also changes in SOFA scores and adverse events. Patients were included if they were adults who had at least 25 mils per kg of fluid over the previous 24 hours to ensure adequate fluid status. And they also had to have a MAP between 55 and 70. And again, the cardiac index of greater than 2.3 and a MAP between 55 and 70. They also had to be on high-dose vasopressors for at least 6 to 48 hours, which was considered greater than 2 mics per kilogram per minute of norepinephrine equivalents. Patients were excluded if they had certain conditions such as large surface area burns, ACS, active bleeding, or were on high-dose steroids, amongst others. So surprisingly, only 80% of patients in this trial had their shock state due to sepsis. So for our population that we're looking at today, post-operative vasoplegia was the cause in about 6% of patients. So I'd like to take a moment to point out the dosing strategy used in the ATHOS-3 trial. And you can recall the dosing recommendations that we reviewed before on just a couple slides back. And this is kind of where those dosing recommendations come from. So for the first 3 hours, so hour 0 through 3, the goal map was 75 and over, and they started at 20 nanograms per kilogram per minute, but the maximum dose was 200 nanograms per kilogram per minute. And then after those first 3 hours, the MAP goal dropped to 65 or 75, and the maximum dose also dropped to 40. So at 48 hours, then, if the patient was responding, they could be tapered off of the angiotensin as well. And if the background vasopressor dose was increased at that time by a certain amount, or if the patient became unstable, they could restart the angiotensin II for up to 7 days. But once the angiotensin II was discontinued for more than 3 hours, it could not be restarted. So for the primary outcome of MAP response at 3 hours, the angiotensin II group had a significantly higher rate of response, so 69.9% versus 23.4%. So this aligned with a 12.5 millimeters of mercury increase versus 2.9 in the placebo group. And you can see this difference here. So for the first 3 hours, this difference was quite robust and quite big, but after those first 3 hours, when the maximum dose of angiotensin II was decreased, the effect size wasn't as stark and wasn't as big. As far as secondary outcomes go, I think most important to note is that there was no difference in mortality. Lower vasopressor doses were required in the angiotensin II group, but again, this did not align to a mortality difference. And so specifically looking at the subgroup of patients who had vasoplegia following cardiac surgery in the ATHOS-3 trial, this was 16 patients. So 9 in the angiotensin group and 7 in the placebo group. And they had similar results. So the MAP response at 3 hours, so the primary outcome, was achieved in almost 90% of the angiotensin II group and 0% in the placebo group. And interestingly, they required much lower doses of angiotensin II to achieve this response. So they started at the 20 nanograms per kilogram per minute for the study protocol, but the median dose that they required at 30 minutes was just about 5, so much lower. So the ATHOS-3 trial has some controversy and some limitations surrounding it. So it was a smaller population, around 150 per each group, but for this population, I guess it's not too terribly small, but most of the patients had septic shock. And so again, when we apply it to our cardiothoracic surgery population, it's a little bit smaller population of 16 patients. And I think the outcome of having a MAP response raises the question of if that's a clinically meaningful outcome. I think mortality benefit or some of those other like multi-organ failure outcomes would have been a little bit more interesting and would have maybe provided a little more evidence for use. So some subgroup analyses suggest mortality benefit, but overall, there was no mortality benefit with the use of angiotensin II. And I think another big question that at least I had after reading this trial was, where do we go after the first 3 hours? So we have that higher maximum dose, but once after those 3 hours pass initially, that maximum dose decreases. And then the safety evidence and the efficacy evidence beyond that 3 hours isn't as strong. So I think that leaves a little bit of question there. And then lastly, there's a risk of thromboembolism associated with angiotensin II that it's important to know. In the trial itself, it doesn't specifically call this out, but in the FDA package insert, they actually cite an increased incidence of thromboembolic events. And so they recommend the use of VTE prophylaxis in patients who get angiotensin II. So if you have a patient who would be contraindicated to get VTE prophylaxis, there might be some risk-benefit discussion that has to be had. These are some other safety concerns that the FDA package insert and the ATHOS-3 trial cites. Thrombocytopenia, delirium, fungal infections, peripheral ischemia, amongst others, were more commonly reported in the angiotensin II group. So overall, angiotensin II has a pretty unique mechanism of action compared to other pressors or agents that we have, but it's not linked to mortality data. It's only linked to improvement in mean arterial pressure. It is pretty expensive, as we showed on one of the first slides. And so I think that leaves some questions to us and good points of discussion amongst the care team, if we should uptitrate other pressors first and use other agents first, or if we should use angiotensin II and monitor for safety and efficacy closely, especially since some of that safety data is not clearly established with that concern for thrombotic events. All right, let's close out with a knowledge check to end. So our last question is, the team decides to start angiotensin II after discussion of the risks versus the benefits. So what dosing recommendation do you have for them? A, we should initiate it at 10 nanograms per kilogram per minute and titrate every 5 minutes to our goal MAP. B, let's initiate it at a rate of 80 and titrate the other pressors off first. C, after 6 hours, we should adjust the maximum rate to 40 nanograms per kilogram per minute. Or D, after starting angiotensin II, we should empirically decrease the rate of other pressors by 20%. All right, I see 1A. And that 1A is correct. The answer is A. We should initiate it at 10 nanograms per kilogram per minute and titrate every 5. So B, we shouldn't start at the max rate. We can titrate up. And C, it's actually after the 3 hours, we should adjust the maximum rate to 40 nanograms per kilogram per minute. And D is incorrect because we don't need to empirically decrease the rate of other vasopressors by 20%. Actually, it may be the better idea to wean off the angiotensin II first based on how long it was studied in the ATHOS-3 trial and to maintain some of the benefit from the other pressors. So overall, I feel like there were some common themes of the presentation. We have some agents with off-label use and some with low quality of evidence with small population sizes and largely retrospective sample sizes. And there's not much data that's comparing the two agents. So often this leads to a good discussion amongst the care team and the providers who have a lot of great experience using these agents. So often it is a patient-specific decision, and we can consider cost when making these decisions as well. So I think as pharmacists, like I said before, we can make sure that monitoring is appropriate for whatever agent we choose. And then we can also ensure that we're complying with our formulary considerations and ensuring adequate access to the medications. So that's all I have for everyone today. I know I went a little bit longer, but I would take any questions that you guys have at this time.